Hello, good morning, everyone. Welcome to the RGPEO's Regional Geriatric Rounds. My name is Jennifer Coop, and I'm the Advanced Practice Nurse for Geriatric Medicine Consult Team and the Geriatric Psychiatry Behavior Support Team here at the Ottawa Hospital, and I'll be the moderator for today's session. Before we begin, we would like to take a moment to share a territorial land acknowledgement for Ottawa, where we are hosting today's sessions. The RGPEO offices hosted at the Ottawa Hospital are located on the traditional unceded territory of the Algonquin and Anishinaabe Nation. The Algonquin people have lived here since time immemorial. We are grateful to have the opportunity to be present in this territory. So today we are honored to have Dr. Heidi Schmaltz and Dr. Darren Burback joining us from Calgary. They will be speaking on optimal management of behaviors in dementia, followed by a time for questions. At any time, you may type a question into the chat box, or after the presentation, you can use the raise hand button, and we will invite you to unmute your mic to ask your question. Dr. Schmaltz is a geriatrician and CME lead for the section of geriatrics at the Cummings School of Medicine. She is also involved in the Canadian Geriatric Society Continuing Professional Development Committee. Heidi completed her medical and internal medicine training at McGill University and a fellowship in geriatric medicine at Johns Hopkins School of Medicine. Clinically, she especially enjoys supporting patients living with dementia and their caregivers. Dr. Burback is a geriatrician and site lead for geriatric medicine at the South Health Campus in Calgary, Alberta. He completed his medical school and internal medicine training at the University of Saskatchewan and his geriatric medicine training at the University of Ottawa. His interests include medical education and the care of patients living with dementia. Welcome, Dr. Burback and Dr. Schmaltz. Thank you for joining us on this early morning.
Thank you very much for having us and for the warm welcome. First of all, our disclosures are pretty boring. You've heard about our appointments, and we have nothing, nobody else gives us money. We will be talking about off-label use of a number of medications in our talk today, and we'll stick to generic names. Our learning objectives really focus on going beyond antipsychotics, and we felt that there's been a lot of discussion around the appropriate use of antipsychotics, and our colleagues had been asking us for guidance as to how to do that and what other options there might be. So we really wanted you to feel comfortable discussing the importance of a non-pharmacological management of behaviors in dementia, develop an approach to that, and appraise the evidence for other drug classes other than antipsychotics. And we've broken our presentation down into sections, and Darren and I will be handing back and forth. I'll be starting with reviewing very briefly the non-pharmacologic evidence. And then when non-pharmacotherapy fails, we've looked at the evidence for other drug classes and their indications. And then finally, that will be Darren primarily. And then I'll come back with just summarizing an approach and resources. And we'll, of course, end with hopefully at least 10 minutes, maybe 15 for questions. So, and these picture slides are just a reminder, just a transition between different interventions that we're looking at today. So starting with non-pharmacotherapy, and we have a case, kind of a composite case of the type of patient that Darren and I see. We work primarily in acute care, inpatient consult service and outpatient consult service. I'm just wrapping up some rural geriatric medicine outreach, and we both do some Zoom. I've done telemedicine as well. So Miss AD or Ada is an 83-year-old woman with moderate to severe Alzheimer's dementia with maybe a vascular component, living at home with her daughter's family. And they've been struggling with increasing agitation, typically at nighttime. And they got to the point where she ended up in the emergency room for this on a long weekend. And her delirium workup being negative, she was sent home with an antipsychotic. So she's now following up with you in your practice a week later, and the yellow is just some prompts as we go through the case between the different components of our presentation for you to stop and think, what would you do? And what do you know about the evidence to guide you in those decisions? So there's a lot of challenges when we talk about evidence-based medicine in geriatrics, as you know, because our patients are quite heterogeneous. And so are the interventions that have been studied, particularly non-pharmacological. There's often not a typical standard, and it can be very difficult to compare. We also know that behaviors in dementia can vary over time, which might contribute to some of the high placebo response rates in some trials. Most of the studies are very poor quality with a high risk of bias and typically of short duration, many of them less than 12 weeks and even shorter than that in some of the pharmacotherapy trials. And when we look at systematic reviews and meta-analyses, there's often quite mixed study results, particularly from one review to the next. I'm going to go ahead and very briefly, and I'm going to try and move fast so that we leave room for questions at the end, talk about some of the evidence for non-pharmacotherapy. And we're blessed to work with Zara Godarzi, who with a number of colleagues had the seminal paper in Annals of Internal Medicine a couple of years ago, where they did a network meta-analysis. They included 168 randomized controlled trials with the idea of statistically comparing interventions that had never really been compared head to head. And the conclusion was that the non-pharmacotherapies were typically more efficacious than the pharmacotherapies. And this can be an overwhelming table, but summarizes the results. So each of these rings is a different type of outcome, from verbal agitation alone in the center to a combination of physical aggression and agitation on the outer ring. The more green it is, the more efficacious the intervention. Each of those initials represents a type of intervention, the red being not efficacious at all. So UC is usual care. The orange triangle highlights some of the typical pharmacotherapies that we would use. And again, that yellow is kind of a 50%, 50-50. And the green triangles highlight some of the non-pharmacotherapies, which you can see are much more green. So knowing that, just looking at different types of non-pharmacotherapy, again, the evidence is very, very difficult because of the variability. Focusing on systematic reviews and meta-analysis, the most or the best evidence we really have is person-centered care, and looking at unmet needs, addressing unmet needs in an individualized fashion for patients. You'll notice that most of these studies for non-pharmacotherapy were studied in long-term care. And again, the study quality isn't typically very good. But we can see towards the left is a positive impact of the intervention, that person-centered care for total agitation, and other outcomes are typically more beneficial. What about other types of non-pharmacotherapy? Well, music-based would probably have the next best set of evidence. And again, in this Cochrane systematic review of 22 randomized control trials, 1,100 participants, again showed a sense of benefit from music versus usual care, less so, not statistically significant when compared to some different non-pharmacotherapy or other activities. And on the right, again, the red and yellow are risk of biases. What about animal therapy? Well, there's both a live animal therapy or artificial, robotic, pet therapy, and ultimately, so there's been a number of systematic reviews, ultimately coming up with kind of mixed results for that. There may be some benefit, but it's not clear. And that may be in part limited by the quality of the studies as well, tend to be quite small. When we look at non-pharmacotherapy on apathy, again, this was a systematic review of systematic reviews in the last year, just over a year ago, looking at 9 systematic reviews, and again, commenting on some of the challenges and the level of evidence, but the majority favored multisensory stimulation, music therapy, perhaps in more severe cases, perhaps cognitive stimulation in mild cases, 2 out of 3 favorable for pet therapy. So maybe, but again, I think the best evidence being a tailored person-centered care approach, and for some people that may include pet therapy or other interventions, and less so for others. Unfortunately, as of now, we don't have conclusive evidence for a number of other non-pharmacotherapies to apply across the board, and that would be non-pharmacotherapy for sleep, aromatherapy, simulated presence, or non-facilitated group activities. So what do you do for Ada and her family who have been given this antipsychotic? Typically non-pharm first, first do no harm. And although we have these limits to evidence-based therapy, we're going to stop the antipsychotic and really try to work on a non-pharmacotherapy approach. Some supports from the Alzheimer's Society, the First Link program, and able to connect her with home care who worked with the family to develop a care plan based on Ada's routines and trying to prevent episodes. But while initially she did well, 3 months later, she comes back to clinic, and now family are concerned that Ada's depressed and they want treatment for this. Ada's never had a known mental health history, but she does present quite flat, more withdrawn, and she's not interacting with family as the way she used to. She's also trying to get agitated in the evenings and nights again. So again, I want you to think about, well, what would you do in your practice and what evidence is there to guide you? So we're going to talk about pharmacotherapies now, because we're going to continue the optimal non-pharmacotherapy we had established and looking at antidepressants. So if we did feel that Ada met criteria for depression and dementia, there were some mixed results looking at antidepressants. The best was for the SSRIs at the top, and that is driven by the one study by Leketsos looking at sertraline. But what about for behaviors if we're not convinced that it is depression itself? Well, there is a Cochrane's, it's getting old now, a systematic review from 2011, looking at 9 randomized controlled trials, the bulk of which were SSRIs. And there was no significant difference in a number of outcomes. Sertraline and citalopram reduced agitation compared with placebo in 2 studies. And they were tolerated fairly well. And of course, the landmark CIT-AD trial in JAMA in 2014 looked at citalopram, titrated all up to 30 milligrams. And this was more of an outpatient trial and did show some significant improvement in a number of scales, with perhaps some, with a significant worsening of 1 point on the MMSE, some QTC prolongation. And there's been a lot of discussion in subsequent papers, because looking at a 9-week trial about the time to onset of action, the duration of the study, QTC safety, and so on. There is an SCITAD study protocol that's been published, so hopefully we'll see some more from that group looking at escitalopram. And in frontotemporal dementia, we've often thought that the serotonergic may benefit, and interestingly, there's been very limited data, perhaps because it's more rare, very small trials, mostly case studies, often open label, no placebos, so really not great evidence for that. So what do you do? What do you do for Ada, whose family really wants that antidepressant prescription? Well, again, revisiting, and agitation is one of my least favorite adjectives. So revisiting what is agitation now, and it is more anxiety with some psychotic symptoms. You've confirmed that they really are optimizing their approach to her behaviors, but they're still struggling to settle her, and it's now jeopardizing her ability to stay at home because of the disruption of her behavior. So although there's no safety risk, their goal is to keep her at home as long as possible, and they're concerned about her distress. So after much discussion around the limits of evidence, everyone agrees to give an SSRI a try. Sertraline and citalopram having the best evidence. And she stabilizes for a while, because this is dementia, and she does progress over the next 6 months to the point where they can no longer keep her at home. And she has a rocky transition into a long-term care facility with poor sleep, calling out, exit seeking, even continuing on the sertraline. She never tolerated citalopram. And now it's the long-term care facility calling you because they want orders. They want you to order some medication. And what do you do now? So we're going to move into some of the other drug classes, and I'm going to mute myself and allow Darren to take us into the next set of studies. Oops, sorry, Darren.
All right, good morning. So we're going to jump into some of the other pharmacologic agents that have been studied. And let's get you to go back one slide, Heidi, please. Great, thank you. So first off, we'll talk about mirtazapine. We're going to talk about its use for agitation. So this is a recently published study, just published in Lancet this year. It's a 12-week multi-center parallel group double-blind placebo-controlled trial involving 204 patients with Alzheimer's disease and agitation. Participants were ineligible if they were already taking an antidepressant or an antipsychotic. 55% of the participants were in the community and 45% were in a care facility. The mean MMSE for these participants was 14.7. And the intervention was mirtazapine, titrated up to a total dose of 45 milligrams daily versus placebo. The mean dose of mirtazapine that was achieved was 30.5 milligrams per day. This was a 12-week trial. And essentially, in terms of the outcome, they looked at the Cohen-Mansfield Agitation Inventory. And for those of you who aren't familiar with this, the Cohen-Mansfield Agitation Inventory assesses the frequency of behavior on a 7-point scale. So from 1, which represents never, up to 7, which is a few times an hour. And there are 29 items. So the range is from 29 to 203 on that scale. And so for this study, they found that mirtazapine resulted in an adjusted mean difference of minus 1.74, which was not statistically significant from placebo. However, what they did find is that adverse event rates were actually similar in both groups, but there were more deaths in the mirtazapine group compared to placebo. There were 7 in mirtazapine group compared to 1 in placebo. And that was a marginal statistical significance at p equals 0.065. So just to summarize, this double-blind randomized controlled trial found no benefit to mirtazapine compared with placebo for treatment of agitation. So next we'll move to looking at mirtazapine and its use for sleep. This was a study that was published in 2017. It was a randomized, double-blinded, placebo-controlled trial involving persons 60 years and over, community dwelling with probable Alzheimer's disease and sleep disorder. And the intervention was mirtazapine at a dose of 15 milligrams daily at bedtime versus placebo. The duration of the study was 14 nights. And in terms of outcomes, these actigraphic sleep data. So specifically using wrist actigraphy, which was used to measure sleep parameters, including nocturnal total sleep time, number of wakenings, and daytime sleep time. And they found that there's actually no improvement in the duration or efficiency of nocturnal sleep. And in fact, there was a somewhat increased level of daytime sleepiness. Next slide, please. So next, I'm going to move on to trazodone. And again, we're going to be looking at specific areas of behavior that it was used to treat and different types of dementia that it was used in. So first off, we're going to look at a systematic review that looked at trazodone in the treatment of behaviors in frontotemporal dementia. So what they identified was a single double-blind placebo-controlled crossover study by Liebert et al. In 2004. This involved 31 participants with frontotemporal dementia. And essentially, the trial duration was 2 6-week periods. Patients were randomly assigned to one of 2 treatment sequences, placebo and trazodone, or trazodone versus placebo. The intervention was trazodone, starting at a dose of 50 milligrams daily. It was gradually titrated up to 150 milligrams per day after 6 days, with a possible increase to 300 milligrams per day as the maximum dose. And that was compared to placebo, as I mentioned. So adverse effects were considered to be mild, including fatigue, dizziness, and hypotension. They found that there was a decrease in the NPI score in more than 50% in 10 patients, and there's a 25 to 50% improvement seen in 6 participants. Improvements were particularly noted in eating disorder, agitation, irritability, and depression and dysphoria. However, a Cochrane review of this trial in 2008, which restricted analysis to the first 6-week period, found that there was no statistically significant difference between placebo and treatment groups. And the Cochrane's review's take on this trial indicated there was no evidence that trazodone is any more effective than placebo in treating agitation in older people with dementia, and specifically frontotemporal dementia. Next slide, please. So next, we'll look at trazodone in treatment of behavior in persons with Alzheimer's disease. So this was a Cochrane review in 2008. It identified a single study by Terry et al. In 2000 involving trazodone versus placebo for treatment of BPSD in Alzheimer's disease. And specifically, that was involving those persons who had agitated behavior. There were 148 participants, and the mean MSE was 14. This was a randomized placebo-controlled trial. The intervention was trazodone, 50 milligrams, titrated up to 300 milligrams, with the mean dose in the trial of 200 milligrams, and it was a duration of 16 weeks. The primary outcome was the clinical global impression of change. And secondary outcome measures included agitated behavior inventory for dementia and the Cohen-Mansfield agitation inventory. And they found that there was no statistically significant difference between trazodone and placebo in the primary or secondary outcome measures. Next slide, please. So how about trazodone for sleep specifically? So this was addressed in a recent Cochrane systematic review in 2020. They identified one randomized double-blind placebo-controlled trial involving 30 outpatients with moderate to severe dementia. The intervention was trazodone 50 milligrams at night versus placebo. And the outcome was, again, looking at the actigraph record. So they found that in terms of nocturnal total sleep time, and what that basically represents is the total time spent asleep each night. So with nocturnal total sleep time, there is a mean difference of 42.46 minutes. This was statistically significant. And there was actually an increase also in sleep efficiency. And that's the percentage of time in bed spent sleeping. But there were no differences on time spent awake after sleep onset, number of nocturnal awakenings, amount of time spent asleep during the day, or number of daytime naps. And in this particular study, they did not find that there were any serious adverse effects. Next slide, please. So while we're talking about sleep, I'll move on to melatonin. Now, often, we think about this because it is a more natural substance and has very low risk in terms of adverse effects. So this particular agent was also reviewed in this systematic review I mentioned in 2020. They identified randomized placebo-controlled trials. There were actually 2 studies that were identified where there was actigraphic data that could be compared and a meta-analysis could be performed. So there's a total of 184 patients in these 2 studies who had moderate to severe dementia due to Alzheimer's disease and sleep disruption. The intervention was melatonin, 5 to 10 milligrams at bedtime, compared to placebo. And in terms of outcomes, again, they looked at actigraphic data, and there was no difference on total nocturnal sleep time, so a mean difference of only just over 10 minutes, which was not statistically significant. And there was no difference in the ratio of daytime sleep to nighttime sleep, sleep efficiency, nocturnal time awake after sleep onset, or number of nighttime awakenings. So essentially, based on this study, there was no evidence for melatonin and use for sleep in persons with dementia. Next slide, please. All right, so we're going to move on to the next agent, which is the class of cholinesterase inhibitors. And we're going to specifically look at behavior in general initially. So this was looked at in a systematic review in 2009. They identified randomized placebo-controlled trials. They found that there were 14 studies, 9 involving donepezil, 3 galantamine, and 2 rivastigmine. There were over 6,000 participants in these 14 studies. 4 of the studies were designed specifically to assess behavioral outcome measures, but in the majority of studies, behavior was a secondary outcome measure. So in 3 of the 14 studies, there was a statistically significant effect in overall NPI score, or in the agitation aggression item of the NPI only. And 1 study showed a significant difference in the NPI score between groups randomized to continue or discontinue donepezil following an open label phase. So just to remind you about the NPI, this is the Neuropsychiatric Inventory. And essentially, it assesses the frequency and severity of behavioral and neuropsychiatric symptoms in patients with dementia based on an interview with the caregiver. There are 12 items with a total score ranging from 0 up to 144, and higher scores indicate greater neuropsychiatric impairment. So of the 4 positive studies, just on that same slide, of the 4 positive studies, 2 used behavioral outcomes as the primary outcome. 10 studies did not find benefit with cholinesterase inhibitors in BPSD, and the majority of those studies were not specifically designed or powered to detect changes. Many actually had low behavior scores at baseline as well. So in the 3 studies with statistical significance, the mean difference on the NPI was 2.1 points, 5.6 points, and 6.2 points. So remember, this goes up to 144 points on this scale. And some authors have defined a clinical response on the NPI as a minimum change of 4 points. So based on that, 2 of the studies perhaps had a modest clinical benefit in terms of behavior. You can move on to the next slide, please. So I'm going to now just talk about cholinesterase inhibitors and specifically the behavior of agitation. So this was looked at in 1 study identified involving donepezil, published in 2007. This was a randomized placebo-controlled trial. It looked at persons with Alzheimer's disease with clinically significant agitation. There was 272 patients in this trial. They were either in a care facility or in the community, and the mean MSE was 8.2. So no antipsychotics were allowed in the study. The intervention was donepezil 10 milligrams daily versus placebo, and it was of 12 weeks duration. The Cohen-Mansfield Agitation Inventory was primary outcome measure, and there were no significant differences in scores. The mean difference in change was only 0.6. And there was no significant difference in the NPI caregiver distress scale, or a clinician's global impression of change. So it was thought that perhaps the modest improvements in mild levels of behavior in other studies may have been due to improvement in symptoms other than agitation. Next slide, please. So next we'll move on to memantine. And specifically, we're going to look at memantine in terms of treatment of overall behavior and mood. So this was addressed in a Cochrane review in 2019. This was a meta-analysis of 14 studies with over 300 participants. Study durations were from
Darren, I think you have to unmute. I think they muted everybody just to cut down on the background noise.
Okay, great. I'm back again. All right, so just to mention that study participants were also taking, some participants were also taking a cholinesterase inhibitor. So the main outcome measure here was the NPI. And again, I mentioned this is a scale or tool that has a score ranging from 0 to 144. So in terms of the outcome, for behavior and mood, using the NPI, they found there's a mean difference of benefit of 1.84 points. So this was statistically significant. However, if you can recall, some authors have defined that the minimum clinically important difference is a change of 4 points. So some would definitely argue about whether this was clinically significant, even though it was statistically significant. Can we move on to the next slide, please? This is just a forest plot of the findings of this meta-analysis, showing that there is the statistical significance favoring memantine. Next slide, please. So next I want to move on and just talk about memantine specifically for agitation. So this was addressed in that same systematic review. They identified 3 randomized controlled trials that looked at memantine and agitation in persons with moderate to severe Alzheimer's disease. And there were 500 participants. The mean MSE scores in one study was 7.5, and the second was 11.9, and there was a range in the third study between 3 to 18. The duration of the studies was between 12 to 24 weeks. The intervention was memantine, 20 milligrams per day versus placebo. So in terms of outcomes, they looked at the Cohen-Mansfield Agitation Inventory. There was a mean difference of only 0.5. This was not statistically significant. And they also looked at the NPI subscale for agitation aggression. And this mean difference was only 0.3, and again, not statistically significant. So there was no benefit of memantine found for use in agitation in persons with dementia. We can move on to the next slide, please. So again, this is just a forest plot showing that with the CMAI, there was no benefit. And also for the NPI agitation subscale, there was no benefit. So I'm going to move on to the next class, which is the anticonvulsants. So first we'll just talk about valproate preparations. This was addressed in a systematic review in 2018. They identified randomized placebo-controlled trials. They found 5 studies of persons with moderate to severe dementia looking at agitation. There was over 430 participants. The intervention was valproate preparations. They varied from 480 milligrams per day up to 1,000 milligrams per day. Trial durations were 3 to 6 weeks, so relatively short studies. And essentially, what they looked at in terms of the brief psychiatric rating scale, the CMAI, there was little or no effect. But the meta-analysis of the 3 studies show that there were higher rates of adverse effects among patients treated with valproate. And the most common adverse effects were sedation, GI symptoms, like nausea, vomiting, diarrhea, and interestingly, UTIs. So no benefit and increased risk of adverse effects with valproate. Next slide, please. I wanted to also just talk about gabapentin and pregabalin. So in terms of these agents, the one review that I could find was from 2019. This was a systematic review. They identified 15 original reports with 10 case series and 5 single case reports. 14 reports involved gabapentin and 1 pregabalin. These participants had primarily Alzheimer's disease or mixed Alzheimer's disease and vascular. Some of the patients had pure vascular dementia or frontotemporal dementia, and 2 had dementia with Lewy bodies. And the interventions was open label gabapentin ranging from 200 to 3,600 milligrams per day, or pregabalin. So in 12 of 15 papers, drug treatment provided some benefit, but there was worsening involving the 2 patients with dementia with Lewy bodies. So it was felt, based on this review, that preliminary low-grade evidence based on case studies and case series suggested possible benefit, but that well-powered randomized controlled trials are necessary. And in fact, there is actually a double-blind, placebo-controlled randomized phase 4 trial currently underway to test the effect of gabapentin, ranging from 300 to 600 milligrams per day on nighttime agitation. Next slide, please. So I just wanted to run over some of the other agents which are not currently approved, but you may hear more about in the future for use of behaviors such as agitation in persons with dementia. So I'll just touch on those briefly. So one of the agents you've probably heard about, combination agent, dextromethorphan and quinidine. So dextromethorphan, as you likely know, it's an approved antitussive medication that acts in the CNS, and it is a sigma-1 receptor agonist. Quinidine is an antiarrhythmic agent that inhibits cytochrome P450-2D6 and thereby prolongs the plasma half-life of dextromethorphan, which has significant first-pass metabolism. So you may have heard about a phase 2 randomized multi-center double-blinded placebo-controlled trial involving 220 patients that found that dextromethorphan-quinidine combination for 10 weeks had a statistically significant effect on agitation compared to placebo in patients with dementia. But this formulation does have a warning regarding cardiac risk, and the assessment of the QTc interval is advised. So there are ongoing studies with this combination. There's a phase 3 study of dextromethorphan quinidine using various doses over 52 weeks that's looking at the long-term safety and efficacy in the treatment of dementia-associated agitation. And this is a different formulation using a subclinical dose of quinidine and deuterated dextromethorphan, and that's to further decrease first-pass metabolism in the liver. So I wanted to also talk about cannabinoids. This is certainly a hot topic right now. I was able to see that, I could actually not find any published studies involving CBD oil and treatment of agitation in persons with dementia, but I do see that there are some small studies that are currently underway. In terms of THC, there was a small placebo-controlled randomized controlled trial that found no difference in the treatment of agitation. With dronabinol, which is a synthetic analog of THC, it was found in a few small randomized controlled trials to significantly reduce agitation, including nocturnal agitation, but over-sedation was a potential concern. And there's also been some studies looking at nabilone, which is a synthetic cannabinoid. There was one small placebo-controlled randomized crossover trial involving 39 people that showed a statistically significant effect in terms of reducing agitation. But the authors indicated that a larger and longer study is needed to be performed in order to confirm the results and to better study the adverse effects, including sedation and possible cognitive impairment. So there's ongoing studies. In particular, I think that nabilone will be the one that's being used going forward, as well as I mentioned CBD oil. I'll next just mention about prazosin. So it's interesting. This agent, of course, has been around for blood pressure control. It's an alpha-1 blocker. and has alpha-1 blocking effects in the CNS. And post-mortem studies have actually shown that there's compensatory upregulation of postsynaptic alpha-1 adrenoreceptors that are linked with Alzheimer's disease-associated aggression. There's been a small double-blind placebo-controlled pilot study involving 22 patients that showed a significant reduction in agitation and aggression in patients with Alzheimer's disease. And a larger phase 2 study is underway. Next slide, please. So I've given you lots of information. I just want to take a moment and we'll just try to summarize the results of these studies briefly. And I think just back one more slide, please, Heidi. Great, thank you. So in terms of SSRIs, in terms of depression specifically, SSRIs may be helpful for mood in non-frontotemporal dementia. With BPSD and frontotemporal dementia, there's poor quality evidence from non-randomized controlled trials suggesting some benefit. And with BPSD in non-frontotemporal dementia, there's emerging evidence suggesting some benefit in non-frontotemporal dementia. Citalopram high dose and sertraline are the most studied agents. Next slide, please. With mirtazapine, for agitation specifically, there's no evidence that mirtazapine is more effective than placebo. And for sleep, there's no evidence that mirtazapine is more effective than placebo. For trazodone, we break it down in terms of BPSD. There's inconclusive evidence that trazodone is more effective than placebo in frontotemporal dementia. There's no evidence that trazodone is more effective than placebo in Alzheimer's disease. And in terms of sleep, there is evidence suggesting benefit in sleep time and efficiency. Next slide, please. So for memantine, looking at behavior and mood, there is high certainty evidence suggesting a small benefit, but again, that was statistically significant, debatable in terms of whether this was clinically significant. For agitation specifically, there was moderate certainty evidence suggesting no benefit. In terms of cholinesterase inhibitors, for behavior, there's moderate evidence suggesting modest clinical benefit. But when we look at agitation specifically, there's no evidence that donepezil is more effective than placebo. Next slide, please. For melatonin, for use in sleep, there's no evidence that melatonin is more effective than placebo. For valproate, for use in agitation, moderate certainty evidence suggesting no benefit. And for gabapentin, pregabalin, there's preliminary, very weak evidence from open label case series suggesting benefit.
Thank you, Darren. So I'm going to pick up here and we're going to go back. If you recall, we left Ada transitioning into long-term care with more behaviors and the facility wanting some orders. And so based on what we've talked about, given her problems with sleep, you tried low-dose trazodone and a plan to perhaps cross-taper with sertraline. But while you're on holidays, a locum comes and changes the sertraline to mirtazapine, rapidly titrates the trazodone, and then adds quetiapine on top. So unfortunately, Ada falls and is sent into acute care where her medications are tapered off. And it turns out she did well just on the trazodone and was able to return back to her home facility. She settled in after a few months and she seemed to be doing well. But this is dementia and things continue. So we'll come back to Ada, but just wanted to review a suggested approach to behaviors and some resources. And Frank Molnar had some great comments in the chat box that I'd like to acknowledge, and that is the issues with type 2 error or beta error, which is the false negative, particularly from small studies. So the fact that there is no evidence for something doesn't mean that there is evidence against something, and that's a challenge also in looking at the heterogeneity of our patient population and the number of the study size that would be needed to really demonstrate significant effects, as well as looking at what we're measuring and how we're measuring it. So I think those are very good comments, and I think highlight what I think most of us know is we're often practicing at the edge of evidence-based medicine, and perhaps evidence-informed might be a better descriptor at times. And certainly there is a certain art to what we do, and particularly looking at interventions of the multidisciplinary team. So when Darren and I we do a lot of work. We're certainly no researchers, but as clinicians and educators do a lot of work with BPSD. In our inpatient service, consult service, we do not have geriatric psychiatry, and so we tend to see the very severe behaviors as part of gateway to the specialized behavior units. And this is our approach that we typically follow is considering the type of dementia, the care setting, the behavior type. Specifically, again, agitation to me can mean so many different things, and the consequences of that behavior. And non-pharm first and always. And we're blessed to work with advanced practice nurses in Calgary who help us with and support the nursing care team, which is often the most important part in developing patient-centered care and looking at unmet needs and tailoring interventions to the person's story. We do consider SSRI as probably our first go-to in terms of behaviors, particularly if mood symptoms are severe and the patient is not responding to non-pharmacotherapy. And while we acknowledge there's no great evidence for melatonin, in fact, most guidelines recommend against it, we do feel that it is one of the safest options. And so having a risk-benefit discussion with family, we'll sometimes do a trial and always stopping if it's not helpful. We don't unfortunately have it on formulary at the hospital, so we are dependent on people bringing it in. Antipsychotics are used cautiously only in situations of severe aggression, agitation, or psychosis that cause severe harm or distress despite our attempts to manage the patient otherwise. And really, I think the appropriate use of antipsychotics is important. Knowing the potential harm, and again having that risk-benefit discussion with family and explaining the black box warning. And again, just a reminder in patients with significant Parkinsonism to stick to quetiapine and consider cholinesterase inhibitor therapy if there's a possibility of Lewy body dementia or Parkinson's disease dementia. As per the guidelines, we don't typically offer valproate for BPSD because the risk of harm seems greater than the risk of benefit. And certainly we've seen that anecdotally on a number of cases. And a key reminder is that it's often a individualized kind of N=1 serial trial that evolves over time. And it's really important that if a medication doesn't appear to be helping after an appropriate trial, that it's tapered off, that we avoid that prescribing cascade. And just to remember, if it's not helping, it might be harming. So with that in mind, Ada, 8 months down the road, developed severe, unpredictable physical aggression to staff and patients. And an antipsychotic is added, initially PRN, and then scheduled and titrated. Unfortunately, she injures another resident and both are sent into acute care with the proviso that Ada can't come back unless her behavior is stabilized. And we see this quite commonly in our hospital. I call it purgatory because acute care is not a great environment for patients, particularly with dementia, let alone severe behaviors. So our team, or perhaps a geriatric psychiatry team, depending on the venue, helps develop a care plan and really optimize the non-pharmacologic management. But because of the severity of her behaviors, a series of medications are tried and titrated as well. Ultimately, despite our best efforts over a number of weeks, the severe unprovoked physical aggression continues, although less often and less severe. But it remains unpredictable, and because of her high care needs, often 3 to 4 staff to manage her behaviors when they occur, she's discharged to a specialized behavior unit in long-term care. we do have a number of resources here for you in our slides that you can access, and I'd just like to highlight a couple of them that you might be aware of these, and I hope I've introduced at least one or two new ones. Choosing Wisely, of course, and the Anti-Psychotics Toolkit, which is expanded on the Restraint as Last Resort Toolkit available through Alberta Health Services, which has a variety of resources looking at education for staff, for families, meaningful activities, and so on. The Alzheimer's Society, of course, here at the University of Calgary, the Department of CME and CPD has a free interactive online module to help with managing behaviors, specifically in long-term care. So you're welcome to check that out. In terms of person-centered care, really enjoyed the checklist and some resources through Saint Esprit, and then some of the guidelines there as well. And I see Barbara asking about memantine for this patient. So we're actually heading into Q&A, and so we'll start off with your question, Barbara. That is a good one, and we used to reach for memantine a lot more often than we have recently because of the slow titration, and we really haven't seen the benefit and have seen some harm with it. But I'll let Darren speak to that as well. If you have any comments, Darren, about using memantine in our patient ADA.
Yeah, I can't, recall specifically, why we may not have tried it in this patient. Certainly, even though we said there's really no good evidence that it's helpful in a patient like this, we have tried in some patients, as Heidi's mentioned. We have had some successes where we felt that it has provided some calming, again, despite the lack of evidence. I think it's something that perhaps could be considered, but, like anything, as Heidi mentioned, being careful. If it doesn't seem to be benefiting at all or seems to be causing adverse effects, obviously, tapering off at that point.
I think we did make the slides available, Samantha, and I believe the session's recorded. So, and I think I'd like to add, and our emails aren't on there. Maybe we can each put them in the chat, but in the absence of patient identifying data, I think we're both open to ongoing discussion or questions via email. And we encourage you to ask them now, either in the chat box or if you'd like to raise your hand and have the moderator.
Yes, thank you both, Dr. Schmaltz and Dr. Burback. This was a wonderful presentation, very informative, very comprehensive. Thank you very much. So if there are any questions, please, you can raise your hand and we'll invite you to speak and bring forth your question, or you can type them into the chat box and we can read them out. Maybe I can start things off with my own question, if you don't mind. Thanks again. And I really liked how you highlighted the need for the non-pharmacological approach and how really effective it can be. We find in acute care often, the culture is we want a quick fix for these things, and going to the medications, the chemical restraints, those sorts of things right away. And I just wanted to, if you had some advice on how do you convince colleagues and families about the importance of the non-pharmacological approach. How do you explain it? What are some advice you have for us as practitioners to promote this kind of approach for patients with behaviors?
Yeah, I'll start first and then invite Darren to add in. I often find it's not so much the families that we need to convince, it's the acute care teams, or sometimes even the long-term care teams. I've done a number of consultations in particularly in rural long-term care units, and it is hard. I think we don't staff, it's a high touch specialty, and unfortunately, at least here in Alberta, our acute supportive living and long-term care staffing ratios are not, I think, what those of us in the business would like to see. Certainly not comparable to young children with similar care needs in daycare which get a 6-to-1 staff ratio. So I think in terms of talking to the team is really, the care team often overestimates the value or benefit of medications and underestimates the risk of harm. They also tend to be less patient and forget the geriatric mantra of start low and go slow. And oftentimes maybe the drug they're choosing is not unreasonable, but they're moving a little too fast or a little too heavy-handed. So I think really education, and that's where our advanced practice nurses can be particularly helpful as well, because the burden of the non-pharm therapy really falls on the care team. It's not us docs coming by who have to deal with that patient in the middle of the night, or who are getting pinch slapped, hit, kick, and whatever. So I think they have been a huge benefit in terms of the education and really providing that teaching and resources around best evidence. For families too, and I think it's really just framing communication in dementia and helping them understand how the brain is working. And often shifting, one strategy that I find quite helpful is, at least in family members that may have had young children, is reminding them that dementia is like going backwards through development, and without demeaning or and with acknowledging the life course and the accomplishments of that person, in order to reach them effectively and communicate effectively, we have to understand that their brain is typically working more like a small child. And so some of the same strategies they used in raising their children or in caring for small children can often be very helpful. And I find that once families are able to let go of trying to communicate or treat their loved one as a rational adult with full cognitive abilities, that often makes a huge difference and lowers the frustration threshold, which then adds to more positive interactions between them. Darren, did you have any other thoughts or comments on that?
I think you covered that very well, Heidi. No, that's fine. Thanks.
So there's a few more.
There's quite a few questions. Yeah. All right. So here's the first. How do you advise acute staff with the most common behavior of patients trying to get up out of bed? We always try to do non-pharm, find the reason, toileting, etc. Often patients still get restrained.
Yeah, us too. I hear your pain, and that is a tough one. And we really recently had quite a devastating case in acute care where a patient was restless and climbing out of bed with severe heart failure and severe delirium, actually, more than dementia, but got IV Haldol and actually never woke up and died a few days later. So I think we hear your pain. We talk about things like moving them into a Geri chair, which is, we talk about least restraint and harm reduction. We talk about trying to put them in a place where staff are nearby or can observe them, and trying to leverage family as much as possible. And it is an ongoing struggle, for sure, especially tying people down so they don't fall. That's my personal bugaboo.
The next point here is speaking about paramedics being called in as sort of a last resort, I assume to people's homes or to long-term care, and just mentioning that they really appreciated the music therapy piece and would try to recommend that. Another question, in a perfect world, what measurement tools would you use to A, monitor behaviors on a daily basis, and B, to evaluate the effectiveness of interventions, non-pharmacological, over a 4 to 8 week admission?
Hey, Darren, you could take that one first.
Yeah, I'm not sure I'm up on all the tools that are potentially available. I can maybe just describe what we use at our site. We have what we call behavior mapping when persons are in hospital at our site. And actually, we find that it's probably most useful in terms of monitoring what's happening at night in terms of sleep. That's where I find it. The behavior mapping is the most useful. What I otherwise find most useful is actually just the documentation in the electronic notes from the nursing staff. So we can actually find out specifically what the behavior involved and what, again, where the antecedents and kind of what happened after an intervention was attempted. Otherwise, the tools that we have don't contain all that information. So we see that, yes, there was maybe some aggression documented, but we need to look at the nurse's notes to get more of the details of what's going on. So I find the tools that we have in terms of behavior mapping most useful for sleep, but otherwise it's the nursing notes which provide more detailed information, which is the most helpful to actually get more information about that specific behavior.
Oh, Darren, that's brilliant. Yes, that's true. And so we'll actually track the number of incidents over time from week to week. We'll look at the number of PRNs that have been used. We'll look at the number of times things like security or restraints have been used over time. It is hampered on units that do not document well, obviously, but yes, that's, and we do touch base with the nursing team to kind of get the gestalt and the between the lines that may not make it into documentation as well.
Thank you. And there's just one last sort of question comment here that I'll point out, and then we'll end up close up here. So isn't this reasonable given the lack of adequate research data that in geriatric practice our clinical approach should be a trial of N or 1?
N equals 1, yeah.
N equals 1, yeah.
Yeah, and I think and really that's what we do, as one of our hospice colleagues says, the voodoo that we do, right? We don't have great cardiology randomized control trials or guidelines. We do one at a time. The other thing that, and that's great that we have paramedics listening in too, and that's wonderful. I think the other thing that we emphasize is that person-centered care is, and I know the clinical nurse specialist that we work with has struggled that sometimes the team kind of roll their eyes. You want me to get to know this agitated patient that's going to help me, and really it does. Understanding that life course and who they are and what are the triggers for them, what's in their history, what brings them comfort, and really trying to use that and reach out to that, I think is really important. So before blanketing music therapy, find out like what works for that person and what might be soothing to them, and just try to leverage that as much as possible and help family tap into that, because oftentimes they just haven't. You have to be really creative and really open-minded. And this is great. There's a reminder of the Behavior Supports Ontario, and yes, and therapeutic recreation team. And I think they are so undervalued. Unfortunately, we lost our rec therapist in our acute care, because of people totally undervalue how important that is. And I think when you have a significantly cognitively impaired patient and you put them in a room and they're not able to initiate or entertain themselves, and there's nothing there but a TV and a strange remote and a call bell, and we expect them to eat when they're supposed to eat, sleep when they're supposed to sleep, and not bother anybody but ring the bell if they need something, is completely unreasonable. And having stimulation and having activities and personalized things is so important, which is why I call our acute care site purgatory for patients who we have to settle their behavior with in this suboptimal environment before they can get back to a residential environment.
Yeah. Thank you so much to Dr. Schmaltz and Dr. Burback for a really excellent presentation, and thank you all for joining us today. Please join us next time at the Regional Geriatric Rounds on Monday, December 20th, with Pam Howell, who will present on tackling medication challenges in older adults, practical tips for everyday practice, and registration is available at our website at rgpeo.com. So thanks again, everyone. Have a good day.
Thanks for having us. Great questions.